All right, we are beginning. We've begun. Very good. Now let us get on with it. This is kind of where we left off. Here's good. Well, getting my ears unclogged, which is just monumental. All right. Effectively, these are some of the mechanics of respiration. This is interesting. What you use and don't use. Breathing is effortless. You expend a very limited amount of energy to breathe, and it's strictly through two sets of muscles: your diaphragm, glorified muscle, dome-shaped muscle that flattens when it's contracted, and the external intercostals. You have two sets of intercostal muscles, internal and external. The external ones will expand the rib cage, the thoracic cage, and in such a way by flattening the diaphragm and expanding it, so you're increasing volume. And of course, again, they have an inversely proportional relationship. If you increase volume, you decrease pressure. That's the impetus. That's the source that allows the oxygenated air, the air to flow in. Again, the comment I made about surface tension on the pleura, on the exterior surface of the visceral pleura, and on the interior surface, effectively on the surfaces of the two pleura, visceral and parietal, that surface tension helps a little bit. Surfactant helps a little bit. Okay, all of that's part of it. When we have to exhale forcefully or inhale forcefully, now we start to use extra groups. So here, maximal force, if you really take that super deep breath, like you're getting ready to blow out the candles, you involve pectoralis minor, you involve big neck muscles, the sternocleidomastoids.
What?
Are you talking about the ear?
No.
I don't know if you went over all of this.
I don't know what we're talking about, actually.
Robin's
I haven't. Oh wait.
They're accessory muscles
Inspiration.
that we utilize. Typically we don't utilize them until the sternocleidomastoid use one. That's a big time muscle. It's super powerful. So what and this is the more interesting thing. When people have respiratory, look, remember I told you that the single most common cause of infectious disease death in this here United States is pneumonia. Most of those folks have chronic respiratory disease was the underlying factor. Have you ever seen somebody with chronic respiratory disease, emphysema, chronic obstructive pulmonary disease, lung cancer? Pick one. Any of those. Effectively, they're struggling to breathe. You're having to, when you're using these extra muscles, it exhausts you to breathe. Imagine that. Just about how much, maybe you had a bad case of the flu or bronchitis, or maybe even had pneumonia. That's the trouble. It's exhausting because you're doing something that should be routine that you don't even think about. Extra energy. It's the same thing if you sprain your ankle and you have to walk cockeyed and use your other. I mean, effectively, with even a minor injury, a stub toe, you start to walk differently. Use other muscles; they get sore. It doesn't have to be. The design of the body is such. Looking at it from my perspective, design of the body is such that we have certain activities we're supposed to be able to do without really an extraordinary amount of energy expenditure. That is one of them. And they're just showing it to you. Normal versus maximal, and they could show you what you're trying to do with maximal on this side and the pectoralis minor and all that type of stuff. That's fine. So what happens? The phrenic nerve, you want to remember that from A and P. Hopefully you do. From A and P, we talked about it. We actually talked about it here. It wasn't AP1, it was AP2. Here, when we talked about the cervical plexus, the main nerve that came out of the cervical plexus was the phrenic nerve. PHRENIC. The PHR tells you where it supplies, branches from C3, C4, and C5 from the cervical plexus. Okay, that's the big player. That's why we worry about people with high neck injuries, falling off a horse, etc. The dome-shaped diaphragm moves downward, expands. Same time, the external intercostals contract, ribs expand, intraalveolar pressure decreases, atmospheric pressure then is even greater than usual. It enhances it by a tiny amount, a couple of millimeters of mercury. The lungs fill up. We don't have to do anything after that. The elasticity of the lung tissues Okay, abdominal organs that have been impacted return to their original shape at the end of inspiration. Okay, surface tension plays a role as well when they begin to shrink, when effectively when the alveoli are no longer expanded, when they're de-expanding, if that's a word. Okay, and so and again, it's not a lot. When we exhale, maybe a millimeter of mercury, but that's enough to push the air back out of the lungs, and it's passive. Again, when we have to deeply the contraction of those additional muscles, abdominal muscles, this is what happens when you're blowing out the candles. Now you're really using those internal intercostals. It's a straining type of thing. You're straining to lift something, you're straining to go to the bathroom. That's what we begin to see. It's a similar process with all those things. You're forcing your diaphragm, so to speak. So again, an expiration, just basically relaxation, elastic recoil, surface tension, okay, all that type of stuff. Which brings us to how we figure what's the use of these things. So it's really a science unto itself. Let me see if they have the illustration. Now I do it in my advanced physiology lab. I have a computer device, and I don't like what they're doing. It's called the iWork system. And effectively, if you see spirometry in action, and you can see it a lot of different places. If you look up spirometry, effectively what they do is you're trying to determine different aspects to determine if you're efficiently using your lungs. Typically, it applies to people who are trying to diagnose either chronic obstructive pulmonary disease or emphysema or something in that category. Really, the distinction is between whether we're dealing with a disease that we call conductive, there's a blockage, there's an obstruction in the conducting system, or restrictive, which means you don't have enough functional lung. And interestingly, emphysema sort of transitions over both of those. So there's lots of, and surely the common denominator is smoking. So you'll see when we get to the chart, you sitting there comfortably, you don't even know it, we all don't. We don't think about breathing unless I tell you think about your breathing, then you think about it. All of a sudden you say, oh, I'm going in and out, and you get distracted, and you'll continue to breathe in and out. Good. You hardly have to remember to do that all the time. So that's part of the internal respiratory mechanism. We don't have to control it unless we need to control it, either to decrease it or to expand it, depending on the circumstance. At rest, between an inhale and an exhale, you're moving about a half a liter. On average, we breathe probably around 12 times a minute. We move in and out. We call that the tidal volume. Okay, and you can see it here. So the tidal volume is really a critical piece. Okay, and we look at all these volumes of how air, so about the effort that's involved, and we measure them using a device that I'll show you in the next slide. Similar, I'll make a few comments about how we accurately measure it. And so the tidal volume is, without even thinking about it, you're bringing in and moving out about 500 or half a liter of air, multiply it times 12. Our average moving in and out of air, about 6 liters. For most of us. A little bit more if you're bigger, a little bit smaller if you're smaller. Okay. That's average, at rest. Then there's different things that are involved. If you think of it, think of how much more you have to bring it in as opposed to blow it out. You have probably about twice as much capacity, twice as much availability of volume to bring it in as you do to blow it out. So those are your inspiratory, the greater, expiratory, the lesser. And then if you take these together, the tidal volume, the in and out, how much after an exhale you have, how much after an inhale you have to bring back in, that's your inspiratory reserve. How much after a typical exhale you have available to blow out those candles, okay, expiratory reserve, all of which are measurable. And then you have what's left over. We call that the residual volume. Residual volume is a function of something we call dead space. It's not all dead in the sense of, oh my goodness. Dead space is space where a certain amount of the air that's in your lungs is there normally within the bronchi, within the bronchioles, within the lungs itself, just to keep them inflated. We talked previously that the big problem with the lungs are not completely inflated, they start to stick to one another. So we have a certain amount of residual volume strictly to keep the lungs inflated. And then over as we age, the number changes. As we might have bouts of the flu or pneumonia, the number may change. We may have some isolated damage. Does it affect us dramatically? No. On average, I would dare say maybe 20% of what we have in our lungs is about residual volume. You can figure this number out. There are tables that you can figure out what we call the total lung capacity. And when I say a table, you'd measure girth around the chest, maybe in a couple of measurements, age, physical, any other physical limitations. There's a variety of measures, and you can plug them into a chart, into a formula, and bang, it'll spit out what your total lung capacity is approximately. But for argument's sake, 6 liters is easy because it's a nice round number, and we can deal with it. When we add any two volumes together, it becomes a capacity. So we have 4 different volumes, and different combinations of these 4 volumes are capacity. And nothing is more significant than that. That's what we call it, vital capacity. That's the addition of the tidal volume, the inspiratory reserve, and the expiratory reserve. The vital capacity is everything but that residual volume. That is a measure that, again, we have a formula for that based on age, gender, body size, chest size, different factors that you should be around. Lots of things. Are you a smoker? Were you a smoker? Environmental hazards. You could just start ticking a variety of boxes. Effectively, with vital capacity, and the word vital tells you everything you have to know about it, it's the amount of available space in your lung that is usable to exchange oxygen and carbon dioxide. That's the vital part of the lung. That's job one for the lung. Go back to what I said the very first time we mentioned the word respiratory. In with the good air, out with the bad. That's what makes vital vital. And so we typically use this for respiratory illness. The other thing it's used for extensively is sport. Because particularly in endurance sports, by increasing these capacities, by increasing the ability to move air in and out efficiently, we can deal with various sports because you're effectively training your lungs to go not only maximum but optimally so. So not only you're breathing efficiently. There's a lot involved in this science. We see it a lot in sport that is particularly associated with endurance. And the first time I really saw it demonstrated was in cycling, like Tour de France type cycling. I mean, it's it was like a documentary or a sports show with Lance Armstrong, despite his failings and having, the cheating that was done, and it's unquestionably that was done. A brilliant athlete, okay, who was a champion before, not a Tour de France, but a racing champion before, who had metastatic testicular cancer, if you did not know, that went to his brain, and still was a world-class athlete. I saw him doing training sessions. They documented he's on a bike. They've got a spirometer in his mouth. They seal off the nose, so and just seal that thing to your mouth. So all you can do is breathe in and out of your mouth, and basically working on techniques to increase this. Because if you're unfamiliar with that race, first of all, it's a great watch on TV. Okay, you get a chance, watch it on TV right around July 4th, and you're doing about 2,300 miles up and down mountains, not hills, mountains, 2 sets, the Pyrenees and the Alps, as well as flats, in 3 weeks. It's a lot of bike riding. 2,300 miles in 3 weeks. You and your bike. Love it. So, yeah, now, this is not a typical, there's a whole variety of them. If this was true accurate spirometry, when we do it here at my lab, my advanced lab, we have nose clips on, and then I don't tape or anything, but we have sterile, removable, like cardboard cylinders that you make the best possible seal. And I have the students deepest breath in, deepest breath out as fast as they can, and you're able to determine certain measures. More on that. And so if you look up spirometry, years ago we used to do this. We had one in the lab before Dr. Robbins got rid of it. Not rid is the wrong term. Cleaned up the lab and moved stuff away. And we had a big drum unit that was basically displacing water. It was not as accurate as these digital and computer-based machines. It works the same way. And I did experiments with both. So here, this is what we look for. The tidal volume, about 500 milliliters. Look at the amount of reserve. With this model, about 46, this is a case where the total lung capacity is the better part of 6 liters. And that's about average. Again, a little, depending on body size, maybe associated with gender. Yeah, not a tremendous difference, but, a little difference. Okay. Typically, the residual volume, roughly this number, again, a little less for women. And here's the vital capacity. You have these three. Okay? And it's about 80%. Okay. And then you have different capacities, but this is really what we're looking at. Okay. More than anything else. We want to know what the total lung capacity is, and there are ways we can determine it because we have an idea of what certain body types are like. And effectively what we do is this, and this is a sort of a universal test. You have the patient or the athlete or the individual basically practice just regular breathing, not thinking about it, and very rapidly take in their deepest breath and blow it out as fast as they can. We measure how much was taken in to how much was expelled, and we look at the differences on the graph, the amplitude. That is called your forced vital capacity. That is the measure. If that is decreased, it means there's too much dead space in your lung, and that person has what we call a restrictive disorder. It restricts their ability to effectively exchange oxygen and carbon dioxide. Again, we see that with pneumonia, we see that with tuberculosis, we see that with different kinds of emphysema. The reason we have them blow that out very rapidly is to determine how fast. Let's say the number, for argument's sake, was 4,600. Okay, something along those lines. How fast should they be able to expel blowing it out as fast as they can, as they're taking their deepest breath, to expel 80%? It takes the normal person who has no blockages, no restrictions, no limitations, about 1 second. Fancy name for that is called the FEV1, forced expiratory volume at 1 second. If that number is, and it doesn't have to be exactly 80, there's a plus or minus about 75 to 85%. We've had contests with it. I remember I had this one guy when I was doing this experiment on the drum unit at Shadyside Hospital School of Nursing, which was done. I was with Chad and we were doing the academics. And he was just a workout freak, nicest guy in the world, but just chiseled. And it was unbelievable. He had 5-6 liters of total of forced vital capacity. Oh my God. And how fast he could get that out. So it was really, and that's the trouble working with healthy individuals, because this is really a test for people or not, which is why I don't do the test. I would be very disappointed in myself after all those, 40 years of heavy cigarette smoking. But we don't want to go there. So they're showing you, here's the vital capacity. So you notice the residual or reserve volume. To me, this is residual volume is this and this color here. And so here's the vital capacity. You can see the difference. Here, and you add them all together, you get the total lung capacity. Here's that time. And it's just what it looks like on the graph. When I do this electrically, it's like we do this, and we get to that person here, and we have them take their biggest and then blow it out as fast as they can. And we can put the markers and calculate how large it was and how rapidly they were able to expel at 1 second, because we have that digital stuff to do it with. I don't have it here. I probably should show you one we've done in the past, just to give you an idea. So some air entering the respiratory tract during breathing does not get there, we call those dead spaces. So air in the respiratory tract that remains in the conducting system that doesn't even get to the alveoli, that's referred to as anatomic dead space. Alveolar dead space, air in the respiratory tract that reaches alveoli that aren't working, they've been damaged, associated with capillaries with poor blood flow, occasionally. Physiological dead space, total of these areas. Under normal circumstances, it's about 150 milliliters per breath. So of that tidal volume of about a half a liter, understand you're still only getting it's 70% efficient with normal breathing. You have 100 of the 500, 150 is dead space. Not useful oxygen and carbon dioxide. That's an important measure as well. Then we get the additional dead spaces due to a variety of factors. A certain amount just not going to get there, and things associated with damage. The beauty of the lung is it's got a tremendous amount of volume for something that's in a relatively small container. So the tidal volume times the respiratory rate gives us what we call the minute volume or minute ventilation. And as I said before, and I will say it again just to clarify that, your cardiac output and your minute ventilation or minute volume have to be the same. You've got to marry how much oxygen your heart needs each minute with how much air you're moving in and out each minute, period. So once again, patting myself on the back, which I'm having trouble taking my arthritis. That's right, treadmill last night. After making sure my wife was in a better mood with the Pirates finally actually winning a game, despite the best efforts of the bullpen to blow it. Going into extra innings, might I add. So I felt I could leave her without her tormenting the animals with her anger. No, so, and again, this is how much air gets there. It's an important value. This has to do with the alveolar ventilation rate because we have to deal with the dead space. And I'll show you the graph. I don't know if it's on here. And then we have other types of air movement that are there. Non-respiratory movements, everything. Coughing or sneezing, laughing and crying. I mean, these are not really that terribly associated. Here, obviously, coughing and sneezing are clearing passageways. And typically, these are reflexive. Okay? And so, I mean, obviously, if you feel something, you can induce more coughing, so to speak. So there's just all those hiccuping, yawning, speaking. All of these are not, even though they are movements of the air, they're not by definition respiratory movements of the air. So let me crank over this. Wrong one. Never mind. It's a wrong one. 21. Good thing I remember this stuff. Basically the same stuff, just a little bit more detail. Better illustrations. Now respiratory movement. Well, maybe show it. Maybe look good here. Where'd it go? Here. Here it is. Here's the chart I was talking about. So if you take a look at this, normally we're 70% efficient. Let's say arbitrarily let's say we're breathing a little faster, but I think they just did this for round number sake. 20 breaths per minute, 500 generates 10,000 minute ventilation, of which we are effectively 70% efficient, where 70% of that is oxygen and carbon dioxide exchange. When you're excited, you're doubling the rate. Oh, yeah. You're hyperventilating. You're only bringing in half the volume, okay, because you're breathing twice as fast. Notice what happens. That 150 never disappears. So you've reduced it to effectively, even though you've doubled the rate, you've reduced the efficiency by 40%, And you're only bringing in 4,000 to try to meet your heart rate, which undoubtedly is going off the charts. So what do we tell people? Take slow, deep breaths. Slow it down, make it deeper. And so if you cut it in half of normal or a quarter of what somebody who is doing, if you can get them to do that, you'll double, or in this case, you'll quadruple the volume, and look at the efficiency rate, 85%. So it can be some fairly dramatic changes that are part of that. So I really wanted to point that out to you. And as we look again, as I go back here, I should have put this together. This is the same stuff I was talking about, volumes and capacities that were there. And there's the same, really effectively the same chart. And again, some of the same numbers, they just use a slightly different set of numbers, doesn't matter. And here's the difference. We use it obstructive. Now, when I tell you about emphysema can create thickening and damage in the respiratory passageways. It can come from bronchitis or chronic bronchitis. This can be allergic. This can be repetitive infections. There's lots of things. And what happens, you can't get the air in and out. And what happens, you see people like this very often get like a barrel chest because they're like sucking air in. There's such and the trouble is once it's in, because of the obstruction, you're forcing to get it in, and the difficulty is it doesn't come out, so they'll get a big barrel chest like that. Versus restrictive, okay, tuberculosis, chemicals, environmental hazards, smoking overlaps both. Decline because the lung expansion is compromised, and typically, and interestingly, they can even breathe it out faster than normal. The trouble is, it's almost like just little puffs. And I mean, it was a fancy thing we used to describe, depending on body types, we call them blue bloaters. I think I have it on my handout. People they couldn't get enough oxygen in, they had a bluish kind of a color, big barrel chest, and pink puffers because they had emphysema and some of these restrictive disorders. Their chest would hardly move, and it was almost as though it was almost like a pinkish discoloration for reasons that weren't necessarily clear. Maybe some retained oxygen in certain areas that were there. So it's interesting. And I think I told you when I was a heavy smoker, if I did, it's a good point to reiterate. I mean, we did chest X-rays when I started my residency, and this 70-year-old radiologist, brilliant, legend, and he said, I understand you're a smoker. I said, yeah. He says, look at your chest. Nothing was anything in the chest. It was chest size. It was the anatomy of the chest. You have this big barrel type chest. He says, you don't stop smoking. He says, you're going to have horrible problems. Because just look at most of my height is in my torso. I have short legs. But a big heart. And he was absolutely right. And I listened to him. Of course, it took me another 30 years, but I listened. We have a saying for people like that. Asshole. I don't want to offend anybody. I'm sure that Brooke's going to report me. When this person who interviewed you told you that I was crazy, what? I could have been a Dickensian character. Was I Scrooge? Was I Bob Cratchit? I certainly wasn't Tiny Tim. Probably the ghost of Christmas past. Maybe Jacob Marley. Not very, in chains. Oh, Scrooge. Certainly wasn't Oliver Twist. I might have been Fagin. He was pejorative because he was Jewish. Okay. The late great Sir Alec Guinness, Obi-Wan Kenobi, played him in the movie in 1948, and he got makeup with his big nose on him. It was brilliant. Okay, and here is the other. Okay, and I thought they had showed you the FEV1. They should have. I must have gone by it, but it's there somewhere. And it's in the notes, which doesn't really, so it doesn't really matter. I just want to make sure I covered it for for your viewing pleasure. So let's bring us into what's going on before we get it. Here's the disorders: bronchial asthma, asthma being a course of chronic obstructive, allergic reactions, pollen, smaller airways, mucus and secretions from the allergic response accumulate since not many cells are ciliated. Okay, and it's true. The smaller airways, you're getting away from the cilia. When you start getting into bronchioles and the tinier bronchi, you're making a transition in the lining. You don't have that pseudostratified ciliated. Irritates smooth muscle, bronchoconstriction, and wheezing. I mean, I had that. I remember my ex telling me I in bed. She goes, just you wheeze terribly. I mean, I'm asleep. How do I know this? Okay, things like that. I know I don't do that now. Because if I was doing that in bed, you know what I would get? I get one of those. So emphysema, progressive deteriorating in which the alveolar walls destroyed, the alveoli merge, surface area. But now what's happening, the air traps in those pockets because now the alveoli have gone from functional to non-functional, and effectively the cavity that they were in is larger but non-functional. They lose their elasticity, blood supply, muscular, as I said, muscular effort to breathe. Okay, and so this is, again, COPD overlaps chronic obstructive pulmonary disease along with, and that's what I mean by trapped air. See, normal pockets, big pockets of entrapment. So that's not useful. Bigger in this case is not better because you have less functional surface area. Okay, those are all important points. Yes?
Does the smooth muscle stop working?
Yeah, very much so. It works inefficiently would be a better word. Stop's probably the wrong term, inefficiently. The other thing is interesting where we have resistance to our breathing. It's funny because resistance is based on total diameter. So even though when the bronchi, as they start to get a little bit smaller, we actually have an increase in resistance. And as they get smaller still, because they're branching so much, we have more and more surface area. It's sort of an oddball phenomenon. So most people, unlike blood vessels where the resistance is in the arterioles, the medium-sized bronchi actually have more resistance than the bronchioles. The problem with the bronchioles is those spasms that they can get associated with allergy, asthma, anaphylactic shock, getting plugged up, so to speak. So breathing as I was saying before, we can hold our breath for a period of time. Okay, you can swim underwater and hold your breath. You can hold your breath. It's like, ooh, walk into some place where it just stinks. You almost want to get through it. Okay, respiratory areas in the brain stem, and that's the importance of the brain stem. Medulla and pons, okay, initiate impulses traveling along the nerves, cranial and spinal, inspiration and expiration, adjusting the rates. So there are in the medulla and in the pons. So you have different groups. You don't have to really get crazy about this. One sets up the rhythm, one modifies the actions of the one sets up the rhythm. So the way I would describe it, it's like a metronome, you know, like that. I mean, so we set a rate, and based on, and it fluctuates a little bit based on what you're doing and your needs. But effectively, the default is going back, let's say it's 12, somewhere average, I'd say between 12 and 15, depending on the author, 12 and 15 times a minute. It's about right. And you'll look at this. You'll be looking at this from a nursing perspective when you're doing vitals. I mean, sure, you'll be taking their blood pressure. Maybe you'll have them hooked up. You'll be getting a digital display. For respiration, you'll just watch the chest go up and down. Not the stomach, the chest. Go up and down. And just, whatever the stopwatch function you have on your phone or on your watch, work fine, whatever, however that would. In the old days, we always had a second sweep hand. It's a little different. I haven't worn a watch in forever. All the jewelry I wear. There's an alarm system if I try to. It goes off in cranberry. It's okay. I had to wash my hands. Dirt got under there. Put it back on. I lost one of these. I have no idea. My wife thinks it went down like in the shower. I had trouble for it. Moving on. And this just shows you what they are a bit like there. I think it's kind of fun. Okay, when it comes to movement, understand the partial pressure. We talk about concentration all the time, right? Higher concentration of partial pressure of gases is the equivalent of concentration. So we know gases move in and out just the way that 5 molar goes to 1 molar, high sodium goes to low sodium, high potassium goes to low potassium. So concentration can be reflective in partial pressures of gas. Okay, it's proportional to its concentration. What is the partial pressure of oxygen? About 21%. Nitrogen, it's about 80%, 78%. Trace gases, the rest that are there. So that's effectively we have roughly what for years referred to as 80-20. 80% nitrogen, about 20% oxygen, and then other gases that are part of it. So we use that, the relative concentration and mixture, to determine. You don't have to know the numbers or anything like that, but that's roughly what it is. So when we talk about an environment when there's insufficient oxygen, it's always going to impact your respiration. So partial pressure of oxygen, partial pressure of carbon dioxide. Breathing, the number one factor that affects breathing, carbon dioxide. That's your impetus to breathe. If you know somebody who is a diver, if they want to do, and there are people who can do remarkable ability with free dive, I cannot. And what do? First? They take 3 deep breaths and blow out as much CO2 as possible. The idea isn't bringing in the oxygen. The idea is to expel the carbon dioxide as much as possible, and then take 1 more breath in and dive. Yes?
Is that why expert takes less energy and less force?
Part of it. It's expiration is a passive process by definition. Elasticity probably plays. You're just relaxing the muscles. But what you're trying to do in that context is to rid yourself of the carbon dioxide as much as possible. Because what happens is your brain, as carbon dioxide accumulates in your bloodstream, it accumulates in your cerebrospinal fluid. And unlike your bloodstream, it's not reversible. The only way we have to blow up carbon dioxide. That's what affects those medullary and pontine centers. So it hits your brainstem, and you can't help it. That's like if somebody's underwater trying to hold their breath until they can get to the surface. So if they can't, there's no way. Eventually, your body's going to take over and force you to breathe, even though there's nothing there, and effectively start to drown. Does that answer it for you? So, usually the batting order of this. Partial pressure of carbon dioxide, number 1 factor. As carbon dioxide increases, this is another one of those chapters where we look at that carbonic acid. Water and carbon dioxide come together. The more carbon dioxide, the more carbonic acid. The more carbonic acid, it's an acid, even though it's a buffer, but the more carbonic acid part of it, the more acidic, which means it's going to lower pH. And then finally, oxygen. And you're going to see this reflected in the oxygen dissociation curve. If we get to the point where low oxygen is forcing us to breathe, we are in big trouble, as you will see shortly. So other things that influence it, stretchability, we call it compliance of the lung. As you and I get older, your lung, it's like any other elastic structure, you lose elasticity. There's a reason I can't swing a golf club as fast as I used to. It just, physiologically, it doesn't work the same way. It's there. Emotional state, as you might guess. So people who are calm versus somebody who's excited, again, inherently you tend to hyperventilate. Physical activity, And there's lots of different receptors that we'll get to that play a role, stretch receptors and chemical receptors. Okay, but the main controlling factor, PCO2 and hydrogen ion, which are tied. Okay, and just in case, and I only write it like 27,000 times, so why not again? Oh, I demand it again. Water and carbon dioxide, your waste products. In your bloodstream, not in your cerebral spinal fluid, there's a magical enzyme for carbonic anhydride. That's what allows the two of these together on a point. That's why your bloodstream is such a good buffer, because it makes a carbonic acid when you combine these two. Carbonic acid is a weak acid, and what's meant by a weak acid, it's much more likely to hold on to its hydrogen or give it up. But if it does give it up, you get hydrogen or bicarbonate. Bicarbonate ion and proton, hydrogen. And so what happens is we have more CO2 increases in any chemical reaction. If you increase the reactants, you increase the products. Well, these are, what happens is because it's an acid, we're going to see an increase in that and a decrease, because these two are proportional. If this goes up, this goes down. So if you add more of the CO2 components, we're going to make the hydrogen. It's just going to make more acid. It's a weak acid. Why do weak acids make good buffers? Because they're much more inclined to hold on to that. They're invisible. You can have my hydrogen here. No, I'll take it back. I'll give it up, take it back. Right now, our white cat is in that situation. Yeah. Cheering at 4 in the morning, okay, he's throwing at your world here. I try to restrain from throwing myself. Close. Have one like that? Loud. White cat. Not tugs, the black and white cat. The dog's name for God's Lincoln. Actually known as Mr. Yes, and he's not president yet. That's what happens. And the difference is in the bloodstream, it's easy because we can, if we get more CO2 or less CO2, we can get rid of it when we breathe. Very versatile. But in the cerebrospinal fluid, we don't have carbonic anhydrase, which means the only way we can get rid of that increased CO2 affecting the medullary and pontine areas of the brain is to blow it off. And the only way you can blow it off is to increase the respiration. Hence, it's the driving force for breathing. And then slightly lesser than that is CO2 is going to kick in first, then pH, and then finally oxygen. That's there. Okay. Low blood PO2 does not have much of an effect. Hydrogen ions do not cross blood-brain barrier well. CO2 crosses the blood-brain barrier. That's what I was saying. Binds to the water, produces carbonic acid. Carbonic acid dissociates and releases more hydrogen ions. They're detected by chemoreceptors. Uh-oh, more CO2, more hydrogen ions, lower pH, directly linked to each other. And I agree, you can consider them equivalent. Increase in CO2 or hydrogen ion in blood leads to increased alveolar ventilation. So this is again, that blood-brain barrier and the absence of that enzyme are the two big factors that are involved. It's scientifically understood. I always thought, fascinating because respiration plays a role. It's like we have, as you'll see, and I'm sure they will do it in this chapter. If not, I just want to throw it out there. As for instance, one of the things that divers get is something called the bends. Okay, so maybe somebody here is a certified scuba diver or has done scuba diving. You have different gas. Remember, our gases are oxygen, a little bit of carbon dioxide, proportionally, in the air we breathe, a fair amount of oxygen, a ton of nitrogen. When you're in pressure, if you go underwater, the deeper you go, it's going to push more. It increases the pressure overlying those gases and pushes them into the bloodstream. Okay? So what do you have pushing in there the most? Nitrogen. So what happens is you get effectively a large volume of gases. What happens, and so over time, that number increases the longer you're down. Divers know this. They have what they call decompression scales. When they go diving, they realize if I'm down at this much footage for this long, I have to make decompression stops. Meaning, if they come up too rapidly, oh my God, there's something wrong with my device, and I have to race up and get, they better have more tanks to go back down. Because what happens when a diver comes up without having those decompression stops, the nitrogen comes out of the bloodstream rapidly and clogs the blood vessels with giant gas bubbles of nitrogen. They get a thing called the bends, which is fatal potentially. Bends has nothing to do with anything other than you're bent over doubling in pain because the gas bubbles are not allowing the blood to get to vital organs. So they make decompression stops at intervals. That's why you sit there with a dive watch on. Okay, we've got to stop here for 5 minutes, here for 7, whatever. I've never done it. My first wife was a certified scuba diver. She knew all that stuff. And did that. She's like a fish in water, one of those. And it's very, very interesting. Now, if someone comes up too fast, hopefully on their boat or their craft, whatever they're using, somebody up there will have some extra tanks. Throw me the tanks, I gotta go back down. And they'll just get rid of their old tanks and have a spare tank handy and be able to do that. And you can adjust the gases and mixes and things like that. Also, for being able to stay under longer and at different pressures. But if you don't do that, then they have to get that person to a station someplace that has decompression chamber. And so effectively can get them into basically a container that can seal, and you can increase air pressure in that container to mimic being underwater, push the nitrogen back in, and over time, maybe hours, several hours, 10 to 12 hours, gradually release it and bring it back to atmospheric pressure so they no longer have or will get the bends. So it's pretty well known. We use a similar idea to treat patients with hyperbaric oxygen. Put oxygen at high levels. If they're, let's say, a diabetic with gangrene, you're trying to force oxygen to the wound. Classically, it's done for burns, for people with smoke inhalation. Because they have carbon monoxide poisoning, we want to force the air into maximally oxygenate. It's not going to displace the carbon monoxide, but will maximally oxygenate the red blood cells. And every day they stay alive, red blood cells that have been poisoned permanently by carbon monoxide die. So every day we keep that person alive. There was a very good movie by I think that was the late Patrick Swayze, called Backdraft, about a firefighter this happened to, and they got caught in a backdraft and severely burnt, smoke inhalation, where people began to see what that was about. And we used to use it therapeutically in different hospitals that had the capability. They dealt with a lot of burn patients, burn units. I don't know if they have it here in Pittsburgh. I wouldn't be surprised. 2 hospitals for burns in Pittsburgh are 2 nationally recognized burn units, Mercy Hospital, on Boulevard of the Allies, and West Penn. I'm sure that's why UPMC bought Mercy, which is an independent hospital, to get the burn unit. I'm sure. And West Penn has been the burn unit for a long time as part of the AGH system. Thank you. We're going.